recording. All right, perfect. All right, so we're going to get started here in about just one more minute, but I do want to let everybody know that your mics are not muted. So if you're not talking, it would be super helpful if you would mute yourself so that we don't hear the background noise, and then you can just unmute yourself as you start to speak. So awesome. I know that there's going to be a bunch more folks joining in, but we're going to go ahead and get started because we have an hour and a half with y'all today, and we're going to take every minute of that, I'm sure. So welcome everybody to the special HIPAA Huddle. This is a 4-week series where we're going through all of the proposed changes to the privacy rule. So before we get started, this call is being recorded. You will all receive a link to the recording either today or tomorrow so that you can play it back and share it with other folks if you would like to as well. Again, this is a special 4-part HIPAA Huddle series that is devoted to speaking on these proposed changes to the HIPAA privacy rule. Your mic is not muted. This is so that we can have a collaborative environment, but if you are not speaking, it would be super helpful if you would mute yourself so we wouldn't hear the background. Also, your video is turned off upon entry. You are more than welcome to turn your video on whenever you would like to, or whenever you're speaking. That would be super helpful so we can see your lovely faces. And remember, like all of our HIPAA huddles, the more you participate, the more we all gain. One more thing that I do want to point out too is kind of why are we all talking about these new proposed changes? And it is because the OCR recognized the need for care coordination. And that is the whole purpose behind the majority of these changes that we're going to be discussing today. With us today, we have Erin MacLean, who is our special guest to help us understand these proposed changes. Erin is an attorney out of Montana, out of Helena, Montana. I almost said Billings, which is the wrong city in Montana. And she is also a partner at Compliance Stride, which is a compliance consulting group dedicated to the healthcare space. Erin, thank you so much for joining us today.
Thanks, Sarah. I'm really excited to be here. I'm, I guess, what you could call a self-professed HIPAA dork. So this sort of thing is really gets me going, and I'm excited to talk about the proposed changes and help people, first of all, figure them out, and second, decide where to go with them if they are implemented. As you and I spoke about earlier, we don't know what the OCR will do with this, so I guess we're just talking about what they might do with it today.
Right, so these are proposed changes. The final rule has not been published yet. When that final rule is published, Erin, you want to talk about how much time that they will have to get everything in place?
Yeah, so there's, in the first pages of the rule, they talk about the 6-month grace period and then the 180-day implementation period. And so we're looking at about 240 days from the final rule implementation, which we anticipate being around March, but of course we don't know. So it's up in the air, and we'll just have to see where that ends up.
All right, perfect. So without any further ado, let's get started. So the first thing we're going to talk about are these new definitions that the OCR has included in the privacy rule. There are two really important definitions that we need to understand, and that is the definition for an electronic health record and the definition for a personal health application. So in starting with the personal health records, you guys are going to see me look off screen because I'm cheating and I have a second screen up with the definition pulled up. So the OCR is proposing to define an electronic health record as the electronic record of health-related information of an individual that is created, gathered, managed, and consulted by authorized healthcare clinicians and staff. So the healthcare record is going to include clinical information as well as billing information, in addition to all the other records that you receive, such as laboratory results, imaging results, and consultative reports from other providers. So that's the first definition of what an electronic health record will mean. And the second is interesting, which is the personal health application. One of the things to really remember here are these are patient-controlled applications. So with a personal health application, these are going to be things like wearable devices, software where the patient is entering in their own health data to control their own health information. So these health applications are not considered business associates, nor are they part of the covered entities organization. They are third-party applications that are in control, that are controlled by the patient. And you're going to get in to see a lot when we start talking about the patient rights here in just a minute, where this definition for personal health application comes into play. Erin, did you want to add anything here?
Just from a technical perspective, they're looking at adding the definitions in at 45 CFR 164.501. And of course, that's where the other definitions in HIPAA are. So that's where they are showing us they're intending to add those in. So in the future, when rules finalized, that's where we can look to see where these definitions will go.
Right. I'm sorry, whoever is talking, can you please mute your line so that we can not hear all the background noise, please? Okay, I think I found it. Hold on. I'm going to just mute here real quickly. There we go. Okay, so awesome. Thank you, Erin. Okay, so the next thing, we're going to actually start getting into some of the meat of what these changes are. So the purpose of the individual right of access is to reduce the individual's barriers to accessing their own PHI. We have seen a plethora of corrective action plans and settlements from the OCR this year in particular, but we also saw them last year, where the OCR is actually citing organizations for not giving patients the correct or timely access to their information. So to help to facilitate this, the OCR is actually making some big changes to this individual right of access to help with that. There are some built-in measures as well to help facilitate healthcare operations, which we're going to actually talk about next week. This week, we're really focusing on this individual right. So the first point that I know Erin and I have talked about at length, and we're really interested to hear what y'all think as well, is that the individuals will now have the right to take notes at their medical visit, which I think most patients already do, so that's not a big deal, but they will also have the right to take photos and videos of their own PHI. So Erin, why don't you tell us a little bit more behind why the OCR is putting this in and what it means?
I think it's a good reminder that this right of access falls outside of the authorization process, you know, where I sign a HIPAA compliant authorization to get my healthcare information. This is that process in which I go in and I say, I want to take a look at what is there, and you have to show it to me, basically, and as a healthcare provider. And so I don't think a lot of individuals know that this is their right. And I think a lot of healthcare providers maybe have not provided for the policies and procedures to allow for patients to access under the current rules. So I think, as you and I talked about, the most important thing is what sort of access do you allow currently under your current policies and procedures in order to then sort of seamlessly go into this place where people can, or, you know, patients, individuals can take notes, photos, videos. if you have a process already where they can access in your location, and you're doing it already, this is not going to be as difficult as the organizations that aren't currently implementing a seamless process for individuals to access their information outside of the authorization process, which of course is current law, but we just haven't talked about it as much. So this is going to cause us to talk about this more. What are we going to do and how are we going to implement it?
I agree. Well, I think too, one of the biggest things that we need to consider too when we're thinking about this is when we're talking about how we're going to implement this is the OCR is actually in this new proposed rule. They've said that the patients will have the ability to make an appointment at the medical records office or to be able to take these photos and videos at the time of an appointment.
Right.
And that gets into some really hairy things, right? So, I mean, I don't know if the OCR has ever been to a medical records room at a large clinic or at a hospital, but they're not exactly set up for patient access. So it's really interesting. I know we're getting a couple of questions. We'll get to those here in just a second. And then also the ability to do it at the time of your medical visit, right? So medical visits at a doctor's office are already booked like so tight. Like I'm lucky if I get 5 minutes of face-to-face time with my provider. And now we're going to add that I'm going to be able to take videos and photos of my PHI at that visit time. It seems almost unrealistic.
So we did have a question that talks about whether an access through a place like MyChart would suffice for this. And of course, we don't know what the final rule is going to look like. It does look as though you have a couple of alternatives to provide access in the location for an individual to take photos, view the information in the videos, and access it also online. So it really is just going to depend on what sort of systems you have, what your location looks like, and what processes you put in place that are compliant. So there is that alternative of internet access. Although if an individual doesn't have the ability to access the internet, you're going to want to consider putting a place where they can access it in your location. And then of course you have to decide, like you said, Sarah, is it going to be done with the healthcare provider there in the appointment, or will the healthcare provider come in, do the appointment, and then another staff member would come in if a person wants to stay longer and, access the information there. So it really is going to come down to what can you do that's compliant with the rule, and taking into account this non-discriminatory bent, of course, that we're always going to be looking at from the OCR, which is how do we make sure that individuals that don't have access to the internet from home or another place are facilitated by your processes. And those are the things we're going to have to think about.
Right. Well, also when we're thinking about patient portals, such as MyChart, we're really limited in the information we can share through the personal health records. Like it doesn't give all the information. And so if I'm wanting to actually see my clinic note, most portals only allow for visit summaries. And so that does not really take the place of what the right of access is. Right. So I think that we may see patient portals evolving like MyChart to have that capability in the future, but I don't think that they're going to have that right away when this rule takes effect. I think that we're really going to need to evaluate, like you said before, evaluate our processes and then put how are we going to modify those in order to correct this. Now, Christina had another good question, which is, I know the rules, like these proposed rules specifically says notes, photos, and videos, but does it extend to the right to make audio recordings of the visit itself?
I think we'll get more commentary on that. And, it seems as though that would be included in the allowance. At this time, I don't know how many people or healthcare providers would deny someone the ability to do that. But I think that they're trying to say here, that's what they're looking for individuals to be able to do, is really be able to make their own record of what it is they're seeing and experiencing in healthcare, to coordinate that care in other ways, you know, and also be able to take that home and remember it for other reasons like that. And Sarah, to go back to what you were saying before, you know, it's not just the policies and procedures we're going to be looking at, but we're going to be looking at our systems. With this new definition of the electronic health record, we then have to determine whether the individual can access the entirety of the electronic health record through the systems and the internet processes that we have in place. So as you were saying, most of the portals right now do not allow access to everything that's defined in that electronic health record. One piece of that is billing. And as we know, they're including those, you know, the billing details in that electronic health record. So all of that, you know, our EMRs and the providers, the electronic the developers, I shouldn't say electronic, but the IT developers, they're going to have to, once this rule is implemented, if it's implemented the way it's written, they're going to have to work together with you in making sure that they're giving you the processes that you need in your EMRs to be able to facilitate this. So that's a lot of this, although a lot of this will be done on the ground when it comes to policies and procedures, the technological piece is we're going to be looking to those IT developers to make sure that they have what we need in order to put the processes in place.
That's a very good point. So here I can say there's a lot that still needs to be explored, right? So, but I also think that this is probably one that's going to stick when the OCR does release the final rule. There is going to be something around being able to take photos and videos of your PHI. So I think that this is something that organizations need to start thinking about. So at your hospital, at your clinic, start thinking about how are you going to allow this to take effect. All right, so are there any other questions on this slide from anybody?
We do have a comment, and I would just say some of these comments are great comments for the OCR. They're asking for comments. And this comment about being able to take photos and potentially video of notes that have not been finalized, I think these are comments that are exactly what the OCR is looking for. So I would encourage these ideas to be forwarded to the OCR so they understand that they need to you know, clarify this in the rulemaking process.
Absolutely. And I'll make sure that I include the instructions which are inside the rule itself on how you can make comments to the OCR when we send the follow-up out. Okay, so here's another big one, Erin, and I know you, Cheryl, and I talked at length about this yesterday, which is the reducing the amount of time a covered entity has to respond to a request from a 30 calendar day timeframe right now to a 15 calendar day. And I know in the proposed rule, it cites that, you know, some states already have this 15-day requirement. And so they think that it is reasonable to put this in place. And then they also put it's 15 days or like without undue delay. So that doesn't mean just because you have 15 calendar days that you should take all 15 calendar days to like respond to the request for access. You should like do it as quickly as you possibly can, right? But no more than 15 calendar days. And I think that's very interesting, right? So like think about now, like where we have 2 big holidays back to back and a lot of people are on vacation, like either one week or the other, and you have 15 calendar days, not working days. Doesn't matter if a holiday or weekend falls in there, it's 15 calendar days, which I think is interesting. So
right. Yeah, the change, as we'll talk about a little later, also coordinates with the ability to request records through your healthcare provider to another healthcare provider, another covered entity. And so it looks as though they're trying to coordinate those, but they really are looking at the fact, if you look in the rule, they dive into the details related to complaints that they've received that healthcare providers push up to day 29, and then they go back to the individual and say, we don't have enough information to provide you with the records today. If you can give us more information, then we'll get you those records as soon as we can. So it really, they're looking at the fact that they've received complaints that some healthcare providers are pushing it beyond the 30 days. So I think that what they're really trying to do is reduce what they see as abuses of the 30-day calendar, and make sure that the 15-day calendar is taken seriously, and that if there is additional information that is needed in order to produce the information, that it's done timely and, like you put here, with no undue delay. And again, it's for that purpose of care coordination and individuals getting their information so that they can receive the treatment that they need. And you know, they do think that because some states are doing it, it seems to be reasonable. And those are the comments that were made in the proposed rule.
I know. So we have an example here to talk about the lab results, right? Because we know too that the majority of the time patients aren't asking for their record in its entirety. They're asking for pieces, right? Oh, you're muted, Erin. The quote of 2020, you're on mute. So here we have the example of like the lab results. So if I were to call and ask my provider for like a access to my lab results, they have to actually provide that within 15 calendar days. And we picked like lab results because typically, and I think this goes to the comment that was made on the last slide too about unfinalized notes, is providers don't always get to non-critical labs in a timely manner, right? And so this is really targeting that to make sure if I request my lab results, I get a look at them, regardless if the provider has actually said, okay, you can release these or not.
And we did have a question, calendar days does not equal business days, correct? Calendar days is, you know, the calendar day on the calendar, business days. Although we know as healthcare providers, all healthcare providers run on a 24/7, or almost all run on a 24/7 schedule. They're looking at business days. If business days is ever used, you know, Monday through Friday, I think is what they look at. So here they are indicating it is calendar day. Right. Yeah, clinic Monday through Friday. Yes, exactly. So if we look at the clinic days, those are more what we take into account as business days. They're not taking into account the business days. They're doing just the flat calendar days in the proposed rule.
Correct. And it is for everything.
Right.
Yep. Okay. So it's moving on to addressing the form of access. So this is, you have to have everything that is like, sorry, I hear like background noise. So again, just a quick reminder that if you are not speaking, if you like, until you have a question, if you can just place yourself on mute, that would be really appreciated. So the next, please put yourself on mute.
Oh, you're also going to a folder? Oh crap, let me, yeah, are they printing out instead?
Can you put yourself on mute, please? Oh my, okay. Mute.
Okay.
I can't mute him either, so just let's let him finish his conversation.
Oh, I need to restart my computer so bad, come on.
Hold on, I don't know how to mute him, ask to mute. Okay, there we go, we got it. All right, sorry. So just a quick reminder, guys, please put yourself on mute. Okay, so now getting back. Individual right of access, addressing the form of access. And this is really important, Erin, because they've put in here really specific things. So anything that is readily producible. So do you want to explain this to us a little bit?
Yeah, so it's interesting because they talk about form and format, and then they also talk about the fact that eventually form and format may end up being the same, you know, especially with apps that we're transferring information to, et cetera. So really the form, when we're talking about that, are we talking about the paper form or are we talking about an electronic form? And then the format really goes into that electronic area of format. Are we talking about a PDF or sort of an internet data exchange? what that's going to look like. So readily producible, they talk about whether that's in electronic or paper form. And of course, you know, it just depends on where you are in your processes, what is going to be the form that's most readily producible for you. And can you respond to requests timely of any form? So can you do it for paper or electronic? And then when it comes to the electronic, what formats can you readily produce the information in? And they're looking at the fact that eventually those two will come together. We won't have paper as much, we'll just have form. And then the format will be just an electronic exchange of information onto a personal application or into another sort of application that people are using in order to gather all of their health information. So, of course, a readable hard copy form, that would be a paper, and there's also readable hard copy forms and electronic versions. And then when it comes down to your policies and procedures, what you can do and what the individual has agreed to. So in the end, in order for us to show that we've done not only what we can do, but what we've agreed with the individual is reasonable, we want to document that. So it's really going to get down to, are we documenting that it's readily producible, that we responded quickly, and that the individual agreed to the form and format that we produced it in eventually.
Right. So this one I think is another really big one, but I think that over time we'll see more electronic adoption for those personal health applications, and we'll see a lot of this kind of diminish over time. At least the amount of work that we're going to have to do to actually implement this. So before we move on, are there any questions on this piece? All right.
Well, as people are trying to generate their questions, the specific language is that where EPHI, electronic, of course, is readily producible in electronic form and format requested by the individual, the covered healthcare provider must, here comes the must, provide the access, including when the individual requests access to the EPHI through a secure standards-based API. You know, we're talking about, you know, the personal application via the individuals, or the API through the person's application. So getting to that space where my health application that I downloaded on my iPhone goes in, and we talked about yesterday, the difference between pushing information to the provider and pulling information from the provider pushing to me. The security pieces are that I think people are going to worry about are making sure that there's no access to the system through that process that could cause security issues. So really our technology reaching a point where we can push information to an app easily upon request without that process implicating security breaches.
Right. And that's also a really good point, Erin, because in this new proposed rule, the covered entity cannot deny that API to the personal health application. So for over security concerns, that's actually spelled out in this new proposal that you cannot deny that. And so that's where I think we're going to see a lot of health applications that are really going for that push versus pulling of information, right? So when we think about an API, which is how softwares can communicate with one another, if you're not familiar with that term, there are two ways that the API works primarily. One is for the requester to kind of pull information out, which means they have access into your application and then they find what they're looking for and they pull it out. And the other one is, which is the push, which was Erin was talking about, is where the requestee actually identifies the data and pushes it out. And so it doesn't actually, the third-party application never touches your systems. And so that's what we're going to see kind of happening.
Right, and it's interesting because this is sort of where we talk about the Cures Act playing into this and the adoption of interoperability on one side under the 21st Century Cures Act, and the comments in this rule that says we're not requiring you to adopt this these electronic software pieces, but if you have them, you have to use them. So we have other laws working in the background, like the Cures Act. They're going to push people to adoption of interoperability. And then this law that's being proposed would then, require the use of it. So it's interesting to see how they're working together.
Right. And no information blocking allowed, right, Erin?
And if we want to talk about information blocking, we can do it in another HIPAA
Another
huddle.
time, yeah. Yes. Okay. So moving on. Oh, look at that. We got ahead of ourselves. So we actually just covered this slide. So we're going to go ahead and move on because this is everything we just talked about. Okay, so this is another one where we can kind of circle back to that previous question we had about the patient portals, right? Because the OCR is addressing the form of access, right? So this is providing a summary of your records in lieu of the actual access. But you will still have, patients will still have that right to obtain the real copy. So if you do provide the summary instead of the actual access to the records, they still have a right to obtain that copy. And then we had the example of psychotherapy notes, Erin.
Yeah, and to go back to the right to obtain the copy, there's a clear directive in the proposed rule that we can offer the summary, but we have to tell the patient that they have the right to the copy. So there's that clear directive that that we have to show in our paperwork when we're providing summaries that we offered the copy and that the copy was either denied or the summary was preferred. So I don't know how that's going to be done. Of course, we'll have to talk about how that'll be done on the ground. But the example of the psychotherapy notes, of course, is that the right to obtain the copy is the right to obtain the copy of the PHI that you would otherwise be able to obtain under HIPAA. And when it comes to psychotherapy notes, of course, that provider has the ability to deny access to those and to offer a summary. And the psychotherapy notes sort of fall outside of this. So the same HIPAA rules will apply to this in the sense that we can still, requests for psychotherapy notes have to be separate, that psychotherapy notes have to be kept separate, and that if there's a denial, then there's a denial process of notification of why there's a denial. And the OCR specifically got into this example here to reiterate that they're not changing the rule, they're just clarifying how this needs to be done if summaries are offered.
Exactly. So do we have any questions on this one here? I think this one's pretty straightforward. All right, we're flying through this. Okay, so addressing the request to disclosures to third parties. So this is where, so I'm actually gonna pull up my second screen again so I can get to the exact things here. Because this one gets really intense, I think, especially when we're talking about mandatory disclosures versus permissive disclosures. So give me just a second.
And, if people do take a look at the rule that was, all the proposed out of the Federal Register, I'm just going to note this is on page 68 because this is a place they might want to go to the bullet points and look at this where they're discussing, where the current provisions are in relation to the SIACS case and what they're doing in response to it. So that's probably a good, the headers actually starts on 67, but 68 is where the substance starts.
Substance starts, yeah, and it goes for several pages here. This is not a small change here. So, and like you said, this is a direct reference to SIACS versus AZAR, where they're like, okay, now we have to change HIPAA because of this case. And so these are the four main points, which is the mandatory versus permissive disclosure, the manner in which the request is made, whether or not it's with or without like a form, and then the form and format of the information provided, and then the fees that are charged. And so when we get into what the OCR is actually proposing here, this is going to be a new section. This does not exist right now in HIPAA.
And the proposal specifically states that the department proposes to create a separate set of provisions for the right to direct copies of PHI to a third party at subsection D of 45 CFR 164.524. And the new D section will better align the privacy rule with the HITECH Act, right, to direct third-party electronic copies of PHR in the EHR. And what's really important about this is it's the direction of electronic copies. So there's an only electronic copies directive in this, and that clarification is going to be very important as we look into how this is going to be adopted in the future.
Absolutely. Absolutely. So, I mean, I think that this one is, yeah, so I'm trying to like get through this because like, just like y'all, this is new. So Erin and I, even though we've spent, I don't even know how many hours reading and discussing these new proposed changes.
So as far as the, you know, the format under the first part of the proposal, the request to direct copies of PHI to a third party will be limited, like we said, only to electronic copies of PHR in the EHR. So that's why the definition of the EHR is so important. And then what is there electronically is going to be so important. And it, you know, it does go back to the HITECH Act, as did the case ruling. And it really does try to bring HIPAA and the HITECH Act together. And so, you know, when it comes down to the, and this is really, again, under the right of access, this is not under the authorization process. So that's another reminder that we're talking about the right of access here.
Well, absolutely.
And so we're, again, talking in this area, you know, on page 72, they talk about identifying the individual and identifying, so is the individual that's making the request identifiable? So we have to be able to identify that person. And also, is the request clear, conspicuous, and specific? And so when we're looking at what the request is, we have to know whether it's clear, conspicuous, and specific, and know that it can be orally or in writing. So again, this right of access is my ability to say to you, I want this directed to a third party, and I can do it orally so long as you can identify me and that my request is clear to you. So I don't think that a lot of us have processed that internally in our medical records departments, and I think the training on this piece is going to be huge.
Absolutely. Well, and then, yeah, and even one of the bigger things to understand too is who is a third party that this information can be sent to.
Right.
Right. So that's not really clear in the rule, but I think that it's any third party.
Right, and they have not said that it's anything outside any third party. So it could be, of course, another healthcare provider, which they're anticipating this is key to because we want to make sure that we're doing care coordination. But it could be an individual that's your friend or family member that is assisting you with your care, or somebody that's in a senior center or somewhere else, you know. So third parties are very expansive here. And then, of course, the fees for this are a huge piece of this. And I don't know if you want to get into that. Are we going to get into that later?
Well, we have a slide on the fees, so I think we can talk about it there. So, but yeah, there are fees that are permissible here as well. So
right, under that third party request, there are fees that are permissible, and they're very well spelled out in the proposed rule.
Yes, we'll get to that here in just a second. So now let's talk about, this one gets really confusing because it's the requester, recipient, disclosure time frame, right? So there's three different like elements to this, right? But it is really meant for this covered entity to covered entity care collaboration, right? So, and it's 15 calendar days each way. So if I'm requesting information, I have, yeah, you want to go into that a little bit, Erin, on what that process will look like?
Yeah, so step by step, I'm a patient and I go to a provider of mine and I say, I want you to get information from another provider. So you, as the healthcare provider, requestor, I believe, no, you're the requestee.
Yes.
Sorry about that. Will go to the next healthcare provider within 15 days and say, I have a patient that says that they want me to get the information, and so I'm requesting it from you. That second healthcare provider, or we'll call them a covered entity because it could be a health plan too. So we have to remember that it's really a covered entity. So covered entity to covered entity. The second covered entity is the discloser, and they will have 15 days to respond to that request so that the requestor can get the information to the recipient, which is, of course, me, the patient. So they've created this 15-day essentially process in order to ensure that information that I think needs to get to a healthcare provider gets to them within that time period. And then, of course, there's sort of this, shouldn't say sort of, there's this no undue delay piece also. And there's quite a discussion about ensuring that the information, that we have policies and procedures in place to address information that needs to go on an emergent basis. So that's going to be another piece that we'll have to address, and hopefully they'll have more clarity to it once the final rule is adopted.
Exactly. And it is 15 calendar days each way. So once the first covered entity receives the request from the patient, they have 15 days to contact the other covered entity. Then that covered entity has 15 days from that date. So like it could take as long as 30 days and still be in compliance. However, it would be highly unlikely for that to take the full 30 days permissible, since it's 15 days each way. Is that how you understand this as well?
Yes, and hopefully I did an okay job of saying that myself, but you did a really good job, Sarah.
Thank you, Erin.
Yes, so that's what it looks like they want to see happen initially, and this process, of course, of requesting through the healthcare provider, this is new, and we are going to have to adopt policies and procedures of how we're going to not only request internally from other providers, but how we're going to respond to requests to other providers that fall under this right of access piece, because this, again, is under the right of access.
Right. So I was actually speaking to one of our clients today, Erin, and I don't know if they're on or not. So if you are, you can speak up. And they were saying, when we were talking about this particular issue, because she called, she was concerned over this, because she said that right now they have these release of information forms that everybody has, right? And that's how they're actually facilitating this. And so her question was, is this just putting a time frame on those release of information? And so, but I think one of the key points here is that that release of information, that authorization, is not necessarily required, because I'm allowed under these new proposed rules to give it orally, which means you cannot require me to sign a release of information form, nor can the second covered entity require me to sign it in order for them to send that information to you. So that's one of these administrative things that the OCR is looking to get rid of through this process.
I think this is a rule for sure that goes to implementing the 21st Century Cures Act and the information blocking piece, and ensuring that an individual can easily request that their provider get information from another provider and that it comes timely. Care coordination. So if you do have a standard release, then you'll want to review that with a compliance professional. And you'll want to review it under the rules as we move forward. And then you'll also want to look at implementing electronic processes, because what the OCR is saying here is they really want to see processes where an individual can sign in and make that request and have it easily flow to you. So they're saying that those electronic signatures that are generated when somebody signs into their chart, their My Chart or whatever space you have, that should suffice for identifying them. And then if they make a clear and conspicuous request, that should easily be able to be transmitted. So if they don't give you the name of the provider, of course, then you can't get that request to the provider. But if they give you the name, address, and phone number of the provider, then you have what you need. And to require them to sign an additional release form would be a burden that would not be allowed under the proposed rules.
Exactly. So, all right, so that was a lot of information. Does anybody have any questions right now on this piece here? Because this one I think is one of the bigger changes that we're seeing. Let everybody time. Okay, so we'll make sure that there's time at the end too, but we're down to our last like 30 minutes. So I want to make sure we get through everything. So records fees. See, I told you we'd get to the fees for records fees. So I think that this has always been like the OCR has released several clarifications on fees for copies of records and accessing records. And so now they're getting really, really clear on what is expected and what is permissible and even further, what is impermissible in charging for these records. And one of the biggest things is they are now saying inspection is always free, always. So, and then it's also free if they're accessing it through their MyChart or some other web-based application.
Right. And this starts on page 78 of the proposed rule, just as an FYI to everyone. And the proposal is on page 79, in case you're listening to this later and want to go see it. The reason that I say that is because as it goes through onto page 80 and 81, there's actually a chart here that details what's free and what's not, and what requires a reasonable cost-based fee. And they're really detailed bullet points that are easy to read and understand on what's allowed and what isn't allowed. So that would be, if you're going to go through the rule, that would be a good place to start on fees 78 through 82.
Right. And I mean, that chart is super helpful that they've put out there. So I would definitely take a look at it if you haven't already. So one of the things that is also really important that is a change is that you have to give notice to the individual of what the fee for those copies will be. You're not allowed to make all the copies and then tell them what the fee is. It has to be done up front. Oh, go ahead.
Oh, sorry, Sarah. They're suggesting that the place in which this will happen is on your website. So that's what they're really anticipating. And if you go into if you read all the way through and you go into all of the costs that they anticipate will be associated with these things, they actually believe that the cost of implementing this will be less than the cost of or less than the money you'll receive back from this. So, and the reason that they're saying that is because they believe that you implementing this fee structure on your website should not cost that much to you, but that it will allow you to charge the fees that you are going to charge for this access right and sending this information to third parties. So I think what's important here is, it goes back to a question that was just asked in the chat is, how is this going to address, companies that make all of their money on doing, this records copying and transfer? I think it will change their business model. It'll create a lot of transparency of what those fees can be. And they're going to have to look at these rules and say, how do we now fit in this new structure? I don't think it will necessarily eliminate anyone initially, but I think in the end, OCR anticipates that a lot of the copying and charges for copying will go away when they talk about the fact that the form and format will eventually merge and there will be electronic interoperability and transfers. And so we won't need those services necessarily.
Right. I think another thing too is we're not allowed to not disclose the copies if the patient is not able to pay. Right? Like that's something that's in the regulation, in the new proposed rule as well, right. Is if the patient, request the information, even if they're not allowed, even if they're not able to pay for it, you still have to give the information.
Right. So there's a encouragement there.
Well,
There's there's a serious encouragement. There's a lot of encouragement from the OCR on this. So when you go through, if you go through the rules, you'll see there's this encouragement of providers to ensure that individuals are able to receive the information they need for care. And so you're going to want to adopt policies that show how you encourage this to happen.
Correct. That's a big word too, encourage. Because I think what's going to end up happening at some point is the OCR is going to encourage with corrective action plans.
But I mean, if they come in and they say, how are you encouraged, how, you know, we've encouraged you to do this, how are you facilitating it? And you say, we haven't thought about it, then that sort of total disregard for the rule. You know, I'm not, of course, we don't know how they're going to address that, because they make it really difficult when they don't throw the must in there, right? They throw us into a gray area. But, you know, it says, do you feel like the OCR is trying to get to the point where the patient has access without a fee? Yes. I do. I think that's going to happen, especially with the electronic interoperability of systems and with through APIs with your personal applications. So I think that that's what they're going to look at eventually as happening. And so, yes, I think, and that it will happen without a fee.
Yeah, I think that that's also another good point. Like when we're talking about those APIs, you can't charge. Internet is always free now. You can't charge for inspection. So I think it's pretty clear that the OCR is trying to move to a point where you cannot charge the patient for access to their PHI, right? Because it's the patient's information.
Right. And so they make clear that when it comes to these fees, we need to be able to calculate the labor for copying. If there's no labor for copying, then there's no fee. Preparing an explanation or summary, if that's going to be done, of course, they allow for a fee because that's extra work, right? So again, if there's supplies involved, there's actual postage and shipping, there's actual costs to the provider that the provider can show, they're not eliminating the ability of the provider to get that covered when it comes to, you know, their costs associated with this. But eventually, I think the OCR sees there will be no cost to the provider in these specific areas. Of course, we talk about other costs that will be associated with it, adopting the technology and ensuring that it's secure and ensuring that the processes and auditing, making sure that we're meeting the timeframes. None of that is allowed to be covered in your cost pass-through to the patient when they make these requests.
Exactly. So are there any other questions on this area? Okay, awesome. Oops. Business associate agreements and access. So we're going to have to do another update to our business associate agreements, Erin.
Right. Yes. I know that's everybody's favorite thing to do.
I was hoping that we would have to change all of our business associate agreements this year. I'm just joking.
Right. Business associate agreements and notices of privacy practices, our notice of privacy practice. We'll get into that in another HIPAA Huddle. But those, of course, are our two big documents. They're not going away anytime soon. And there is a clear, there's a clarification here that talks about whose responsibility it is to disclose the information to the patient. And the new rule suggests and actually requires that if you want your business associate to be the individual who makes the disclosure, then that will be in the business associate agreement as a requirement under that agreement. Otherwise, there's a presumption that if an individual goes to your business associate, the business associate will pass that request to you, and you as the covered entity will be responsible for responding. So, of course, in addition to putting who is or is not responsible, you're going to want to put in your business associate agreement what the time frame is for the business associate to tell you that it needs to be done, because we're going to be looking at a shorter time frame. So we want to change those time frames in our business associate agreements too. So there's a couple of pieces here that are going to need to be addressed.
I know it's actually quite a lot that's going into this business associate agreement clause or change.
Right.
So, and I think that the majority of covered entities are going to just add in a clause that says business associate must disclose within 5 or 10 calendar days, however, of the disclosure request. You know, you can't, well, really, I wouldn't wait 5 or 10 days. You only have 15 days to respond to the request. So within 2 business days.
And if you're talking to your compliance professional or your attorney about this, they can go to page 93 of the proposed rule. So that's where they can see that particular information and those particular changes that are proposed.
Yes, but we are going to be seeing major changes to the business associate agreements when they do come through. And I think that it's really important to know that that means that you're going to have to get a new business associate agreement with all of your current business associates, as
Right.
well as ensuring that your future business associate agreements are in compliance with this. So
Right.
one of the things you can do right now to prepare, even though this has not been a finalized rule, we know that this is probably one that's going to be in the finalized rule, is start looking and identifying business associates that you may want to allow to have this disclosure permission. And if you identify anybody, put them on a little list so you know to contact them and you know exactly what to do and add that verbiage into your
Right.
business associate agreement. If not, just know that you're going to have to add in a clause and update all of your business associate agreements once this is published.
Sarah, I think it's a great point. Of course, you never plug HIPAAtrek, but I'm going to right now. This is one of those areas where if you have a platform like HIPAAtrek, you can go in, you can put in who are your business associates that you have agreements with. You can keep the agreements there. You can know what the agreement is. You can audit what's in there, and then you can assign any changes that need to be made to someone who needs to make those updates. And again, one of those assignments that can be made is to actually call the business associate that you think is going to have this permission and let them know, because this is something, if you just send them a business associate agreement, a new one, and you don't tell them this is in there and that you've changed it, then you're putting both your covered entity and the business associate in a difficult position of not understanding the new process. So when it comes to these sorts of processes, the HIPAAtrek platform really does provide an individual or an organization a great way to say who's going to do what and what needs to be done. And as we move into these new rules, if they're adopted, we're going to want to have those in place, because it's sometimes going to, not only do we need to see what we have in place over the next couple of months so we know where to go from there, but we're going to need a platform to organize it for all of us. Whatever you use, we're going to need a space where we know what we have and where we want to go next.
Exactly. I mean, in with HIPAAtrek too, just for 1 second too, is you can also just sign those business associate agreements through the platform, so you don't have to do the whole back and forth DocuSign, like uploaded to DocuSign. Everything is all done in one place. So, but now we're finished plugging and moving on to the next point. Okay, so patient identification verification. To me, this one is a really, really big one, because I remember when the red flag rule came out and all that discussion on whether or not the red flag rule applied to healthcare entities or not. And so I think that the OCR here is making it really, really clear that the red flag rule does not apply to healthcare organizations, because they're actually even reducing further that burden of having to unreasonably identify yourself. And they're getting like really specific on this unreasonable identification measures. So this doesn't mean you don't have to verify the identity. You 100% absolutely do. But what they're saying is you cannot make me fill out a form to prove my identity. You cannot require a certain type of identification. So you can't say, show me your driver's license. If I want to show you my like state ID card or my passport or my something else government issued ID, you know, you can't specify what type of ID it is.
Right. So the proposal on page 103 says to address ongoing challenges and barriers, or these ongoing challenges and barriers, those that they had gotten into in previous pages, to an individual's access to their health information, the department proposes to modify. So now we know where there's a modification, paragraph 2V of 45 CFR 164.514H, to expressly prohibit a covered entity from imposing unreasonable identity verification measures on an individual, and then in parentheses, or his or her personal representative exercising a right under the privacy rule. So again, I mean, that goes into, as they talk about notarization requirements being made by providers.
That's crazy.
Yes, and when they get into the reasonability standard, they really are changing what is reasonable, both here and other places that we'll talk about in other HIPAA huddles. But that reasonable standard is going to be based upon, of course, the OCR's perception of what is reasonable at any given time frame in history. So, you know, we're talking electronic signatures, thumbprints, you know, facial identity, all that sort of thing. So really staying up with the times is going to be important. And what they indicate too is that if somebody's your patient and they've come in for a patient visit and they've been verified by the provider as a patient, and then they say, I want to make this request, and you say, but I need more identity for, you know, identity verification from you, it's entirely unreasonable for you to treat someone whose identity you believe is that identity in treatment and then ask them for additional identity verification. So there are going to be circumstances in which it's going to be extremely unreasonable for you to ask that identity verification. And then there's other examples that they give, such as somebody calling on the phone, where you're going to want to have more identity verification requirements. So you're going to have to look at your policies to say, where are you requiring it and where are you not requiring it because it would be unreasonable?
Exactly. So I think this is going to actually be a good thing for hospitals and clinics, which is like who we both work with, right? So I think that our clients are going to really benefit from this reduced burden of identification and being able to say that they've made their best efforts. So we finished right in at an hour, which is really good, y'all. So I want to take a moment and just see if there are any questions. Okay.
There's a chat that popped up on voice recordings.
It would be handles the 15 all party consent states. Yeah, I actually live in one of these all party consent states, right? So in the state of Illinois, it's everybody has to consent to the recording. But like one state over in Missouri, like it's one party consent. So the person making the recording is the only one that has to consent to it. So technically speaking, a patient right now in the state of Missouri, I guess they could record the visit without permission from anybody else. They could do it covertly, like sticking their phone in their pocket, or I mean, but technically they could do that. It is interesting, in my opinion, that audio recordings were not included in this rule. I know for like some providers, back when I worked in nephrology, we had a lot of patients whose caregivers asked to record the visits, and we always allowed it. I know my dad records his oncology visits. You know, I know that some providers do this already. So I think it'll be interesting to see. Oh, thank you. Dina just posted a link to all these proposed rules that we were talking. Thank you so much, Dina. So yeah, so next week we're going to get into, we're only covering 3 topics. So this week we covered 4, but next week we're going to cover 3, and their reason is they're kind of big. So we're going to talk about the amended definition of healthcare operations. So this is the O in TPO that everybody struggles with. And so they're actually amending that definition, and we're going to talk about that next week. Then we're going to also talk about the exception to the minimum necessary standard, which in my opinion is something that everybody always struggled with to begin with. So it's pretty cool that we're going to be talking about that, and they're trying to address it. And then clarification of a covered entity's disclosure to third parties. So we're going to get more into these third party disclosures. You can say thank you to Seox for a lot of this. So,
hey Sarah, I was going into put in the HHS website for their press release on this, and I accidentally I had apparently in my I had copied previously the Compliance Stride Inc. website. I did not mean to put that in there. I'm so sorry to everyone. The next link was the link to the HHS proposed modifications, and it of course then links to the Federal Register, but it gives you the the policy considerations around what's happening and what they're proposing to do here. So yeah, and I think that getting into the next couple of HIPAA huddles, we dealt with a lot of, specific detailed access rights and fees today and definitions. We're going to get into a lot of policy when it comes to these next pieces. And I think that's going to be really interesting to see how that coordinates with what we talked about today.
I definitely agree with you there, because there's going to be some actual work that has to be done to implement next week's topics. So,
and bringing in the definition of healthcare operations and really solidifying that in a manner that they had not before under HIPAA. I always wondered why they didn't make that more clear. And I think they didn't have clarity on it themselves over at OCR and over at HHS. And now I think they're really diving into having that clarity of what is healthcare operations, what is treatment, and when can they overlap? And there's a lot of discussion about that.
I know, I can't wait. And I can't wait to hear everybody's voices next week. So please join us next week at the same day and time. So it's next Tuesday at 1 p.m. Central Standard Time to hear on the next bunch of proposed changes that we're going to discuss. Same bat channel, same bat time. Oh my gosh. So thank you, Mike.
Anybody that's on here, we would like to know your thoughts. I know Sarah and I are considering also what part we can play in making comments. What are your thoughts from an internal perspective of what we talked about today? And where are you when it comes to your processes in relation to what they're proposing? If anybody is interested in sharing or is willing to discuss it with us. I think they're asking Sarah if they'll get a copy of the slides.
Yes, you will get a copy of the slides as well as the recording. So Bethany from the HIPAAtrek team will load all of the recording into YouTube and then send the link out once that happens. So you'll get the YouTube link here soon. And then you will also get the EMR. So Melinda's actually saying something quite interesting, which is, I'm not sure the smaller EMR vendors will be able to make the changes needed in time. I actually disagree. I think that the smaller EMR vendors may be able to move quicker because they have less politics that they have to work through than the larger EMRs. Two, their software is not quite as complex, and so they're able to make the technical changes. I think that the only challenge that they may have is going to be the cost of implementing the changes, where the larger EMRs will be able to do that very quickly. But in my opinion, when personal health records first came out, you saw the small EMRs facilitate and get those personal health records or patient portals out much quicker than the Cerners and Epics of the world, right? So Allscripts, Athena, CPSI, they all got their patient portals out before Cerner and Epic did.
Right, and who is going to pay for it? Are they going to pass it on? And is the cost going to be so high that providers not understanding some of the interoperability requirements and some of these requirements won't do the updates because it will be costly to them? I don't know. You know, the question is will you get it as part of your package that you pay for annually or on an ongoing basis, or are you going to have these as add-ons? And if we don't know the answer to that, right? I mean, that's going to be the question moving forward. And as we move into the fall, what sort of additional costs are going to be there and for what parties? Also, there, you know, that's sort of outside the provider, right? What costs are coming in. And then Sheila, I totally agree. One of the issues we have with, you know, telehealth, with any changes internally, are the providers modifying their practices in a manner that makes it easier for us to do our jobs in the administrative areas, right? So how are we going to train our providers and our other staff in order to allow for this? And then how are we going to work together with the providers to make it so it's not an additional burden on them? I don't know how quickly we'll get to a quality space, but if we're still working at our RVUs and providers are trying to get in, you know, their fee for service visits, and we're trying to put in the middle of that in these spaces the ability to, you know, record and take pictures and videos. How are we going to allow for that, not impose barriers, but still allow for the providers to treat patients and do their jobs? Those are big questions we're going to have to answer. And then once we start figuring it out, training everybody so it's well coordinated and people aren't upset about it, not knowing what's going on and why. Right. So I think that's going to be part of what we're going to look at, how we do that.
Right. And so I think one of the biggest challenges is going to be in the HIM departments with this, right? Because when we think about, so clinic visits, it's very, it's easier for the provider to finalize the note the same day that the patient is seen. In an inpatient environment, that is much more difficult to do. The providers are balancing a lot of times clinic visits as well as inpatient visits, doing their rounds, doing everything, signing the orders, and then since the dawn of HIM departments, the bane of every HIM person has been tracking providers down to get them to sign their records, right? And so I think one of the points that we're going to have to really understand that's not really clear in this proposed rule, and I think somebody mentioned earlier, is will the right of access extend to unfinalized records?
Right.
And I think that if it does, HIM departments and providers are going to clash like they have never clashed before. And it's already a contentious relationship at times between HIM and providers, and you're going to see that get even more difficult. So I would, and a lot of times, at least with our clients, the privacy officers are the HIM directors. So not only are they responsible for the HIPAA side of everything, they're also responsible for all of this. And so it's going to be extremely difficult.
Right. And who's your compliance oversight person, right? You talk about your privacy officer, but where's your compliance coming from? Is it coming from an outside compliance individual who's bringing this information in, or is HIM trying to manage the compliance auditing and oversight in addition to all of the other work that they're doing?
Right. When you look at critical access hospitals and small short-term acute hospitals, it's 100% in the HIM department. There is no other compliance oversight.
Exactly. Yeah. And so they're trying to manage everything. And of course, if there is a compliance committee, they're having to go to the compliance committee and verify what they're doing and talk about what they're doing. And at the same time, accomplish all of these goals with the providers and then ensure that the training's done so that everybody knows what they're supposed to do. So I think that the costs are underestimated. I think that OCR is definitely not taken into account how all of these processes that we're discussing actually get implemented on the ground and who deals with them internally, and that there's only 24 hours in a day. So it's really, I mean, one of the things you and I talked about, Sarah, is one of the things that we do at Compliance Stride is step-by-step people through how to do this without going insane. You know, keeping your sanity and getting to where you need to go while trying to get all of the processes done. And that's going to be, you know, us all staying sane is going to be challenging. Yeah.
So Sheila just made another comment. If you don't have a strong medical staff, HIM is not supported to obtain signatures on deficient records. I think the definition of designated record set is so important now. I could not agree more.
True. Yeah,
I could
absolutely.
not agree more. And I think one of the clarifications we really need to know is, can we leave this as the designated record set? Or again, does it extend to these unfinalized records, which by definition are not part of the designated record set until they're finalized? So what does that, where does that leave us?
And where do they sit? Yeah, and where do they sit in your EMR, right? Like, are they showing up in your EMR before they're finalized? And so those are IT coordination pieces, right?
I 100% agree. I think this is going to like change a lot of how we operate. So awesome. Well, we're just about out of time. So like last minute questions, anybody?
Or requests of what you want us to cover in addition to what we've already stated we're going to cover in the next huddle. If there's anything else that you think you want to see more in depth, please let us know and we'll make sure that we cover that for you.
All right, awesome. Well, thank you so much, Erin, and thank you to everybody. We had a few people hang on to the very end, so thank you guys so much. We really appreciate all of your time.
Thanks, everybody.
All right.
See you next week.
All right, bye, y'all.
Happy New Year. Bye.
Happy New Year.